Okay, let's dive in. Imagine this scenario. A patient's seizing, it's gone on for 5 minutes, maybe more, and the first drugs you reach for the benzodiazepines, they just haven't worked.
Mhm.
That's when you're facing a real emergency, benzodiazepine-refractory status epilepticus, BRSE.
And it's incredibly dangerous. I mean, the source we're looking at today really hammers this home. Mortality rate cited anywhere from 35% up to 60%. It's huge.
Wow. 60%.
Yeah, so when that first step fails, you desperately need something else that works and, works fast.
Right, and one of the main second-line drugs is levetiracetam, LEV. It's a pretty common anti-seizure medication.
Very common.
But here's the rub, and this is what our source gets into. There's actually quite a bit of confusion, or maybe uncertainty, about the best dose to give right off the bat. The loading dose.
That's exactly it. We just haven't had studies directly comparing different LEV loading doses head-to-head in this specific situation in BRSE.
What do people do?
Well, you've got international guidelines, often based on trials like ESET, suggesting weight-based dosing like 60 milligrams per kilogram up to a max dose.
Okay, weight-based.
But then you also see fixed doses being used, not adjusted for weight. And complicating things, some previous studies trying to look at different doses, they've had kind of mixed results, sometimes even negative.
Which leaves doctors making these critical calls without crystal clear data.
Precisely, in a high-pressure moment.
So that brings us to our mission for this deep dive. We're going to unpack a specific study that tackles this head-on. It's a retrospective cohort study published in the Canadian Journal of Neurological Sciences.
Right. And it directly compares two weight-based LEV loading dose strategies for adults with BRSE. They set a threshold.
What was the threshold?
They defined a low dose as less than 30 milligrams per kilogram and a high dose as 30 milligrams per kilogram or more.
Okay, 30 millig kilogram. Why that number? Seems a bit specific.
Yeah, the researchers themselves say it was somewhat arbitrary, but the idea was to pick a point that might capture some of the common fixed doses you see in practice. Like, think about a 2,000 milligram dose for a 70 kilogram person that works out to roughly 30 milligrams.
Ah, okay. So it's a way to compare doses around a commonly used benchmark.
Exactly. And this study looked at data from Vancouver General Hospital between late 2022 and the end of 2023. Included 106 adult patients.
And they weren't just looking at whether the seizure stopped, right?
Yeah, they looked at effectiveness terminating the BRSE, but also safety and other really key clinical outcomes.
All right, let's get into the details. How did they set this study up?
Okay, so as you said, single center, looking back at records retrospective cohort.
Right.
They included adults, so 18 plus, who showed up at the ER with convulsive status epilepticus seizures lasting at least 5 minutes.
Right.
And crucially,
They had already failed the first line.
yes, they had to have received at least one dose of a benzodiazepine, like lorazepam or midazolam, but were still seizing. That's the refractory part.
Got it. They're really tough cases. Any exclusions?
Yeah, they excluded patients where the seizure might have been caused by something else, like a recent traumatic brain injury or, drug overdose, alcohol withdrawal, things like that.
Okay.
And one other point, continuous EEG monitoring wasn't required for inclusion. They were mainly looking at the clinical picture documented in the records.
Okay, that makes sense for a retrospective look. So the main goal, the primary outcome, was stopping the seizure.
Correct. Successful termination of BRSE. But because they were looking back at charts, it's sometimes hard to pinpoint the exact moment a seizure clinically stopped.
Right, documentation might vary.
Exactly, so they used a surrogate marker.
A stand-in measurement.
Pretty much. Their surrogate for success was, did the patient not need any additional anti-seizure medication right after getting that LEV loading dose?
Ah, so the logic is, if the LEV worked, you wouldn't immediately reach for another drug.
That's the idea. The authors felt it was the best objective measure they could reliably pull from the electronic health records.
Okay, practical. What else do they track, the secondary outcomes?
They looked at some really critical things. Whether the patient needed endotracheal intubation, a breathing tube,
Yeah.
if they needed to be admitted to the ICU, the intensive care unit,
Okay.
30-day all-cause mortality, did they survive the next month, and also any documented adverse drug reactions to the levetiracetam.
So really looking at the downstream consequences, tell us a bit about these 106 patients. What were they like?
Sure. The median age was about 63 and a half. Average weight around 70 kilos, so about 154 pounds.
Okay.
About a third, 36%, had a known history of epilepsy. And for most of them, around 70%, the cause of the seizure was thought to be structural-like damage from a previous stroke or a brain lesion.
And the first drug they all got was a benzodiazepine.
Right. Mostly lorazepam, that was about 79%, or midazolam and the rest.
Hmm.
And the authors made an interesting side note here. They observed that the median initial doses of those benzos seemed, well, maybe a bit low compared to standard recommendations for status epilepticus.
Really? Subtherapeutic.
Potentially. They acknowledge it wasn't the focus of this study to analyze the benzo dosing, but it's, important background context.
Yeah.
These patients might have received LEV partly because the first-line treatment wasn't optimally dosed.
That is interesting context. Okay, so they get the benzo, it doesn't work, then comes the LEV. How did the dosing split between the low and high groups?
Right. Based on that 30 millikilogram cutoff, there were 62 patients in the lower dose group, so less than 30 kilograms, and 44 patients in the higher dose group, 30 milligrams or more.
So slightly more fell into that lower dose category in this particular hospital's practice during that time,
Seems that way, yeah. The overall median dose for everyone was 28 milligrams.
which is just under that threshold.
Right. And that translated to a median total dose of 2,000 milligrams. In the low group, the median was 20.5 milligrams, or 1,500 milligrams total. In the high group, it was 39 milligrams, or 2,500 milligrams total.
And did anyone get really high doses?
The maximum dose recorded was 62.5 milligram kilograms, which was a 4,300 milligram total dose, still within the generally accepted max of 4,500 milligrams.
Okay, paints a clear picture. Let's get to the results. The main event. Did the dose make a difference in stopping the seizures using that surrogate marker?
Yes, this is really the key takeaway. Overall, about half the patients, 51%, achieved that surrogate outcome. No further ASMs needed immediately.
Okay, 50-50 overall.
But UT, when you split by dose group, it was significantly different. In the high dose group, 66% achieved seizure termination,
66%. Wow.
compared to only 40% in the low dose group.
40% versus 66. That's a huge gap. Almost 2/3 succeeding in the high dose group versus less than half in the low dose group.
It's a very substantial difference. And they didn't just stop there, they did statistical analysis to adjust for other factors.
Adjust. What does that involve?
It's a way to statistically level the playing field. Maybe just by chance the groups differed slightly in age or kidney function, which they measured using eGFR, estimated glomerular filtration rate. Things that could also affect the outcome, besides the dose.
Why kidney function?
Because LEV is cleared by the kidneys, so how well your kidneys work can influence drug levels and potentially the response. They found eGFR did seem to matter, so they included it in their adjustment.
Okay, so they're trying to isolate the effect of the dose itself. What did the adjusted analysis show?
It confirmed the finding. After adjusting for age and eGFR, the patients in the higher dose group still had significantly higher odds of their BRSE terminating. The adjusted odds ratio, the AOR, was 3.07.
Okay, stats talk. Odds ratio 3.07. Break that down for us. What does that mean practically?
It means, roughly speaking, that patients getting the higher dose were about 3 times more likely to have their seizures stop compared to those getting the lower dose, even after accounting for those differences in age and kidney function.
3 times more likely. That really strengthens the case for the higher dose being more effective at stopping the seizure itself.
It certainly does.
What about those other outcomes? The clinical impact breathing tubes, ICU.
Also very interesting findings, although the study wasn't primarily powered for these. They saw consistently better outcomes in the higher dose group. For intubation,
Needing a breathing tube.
it was needed in only 11% of the high-dose patients, compared to 24% of the low-dose patients.
Less than half the rate.
And for ICU admission, it was 16% in the high-dose group versus 26% in the low-dose group.
Again, a noticeable drop. So better seizure control seems linked to less need for intensive support.
That's what the association suggests, yes. And then there's mortality.
The 30-day mortality rate, what did they find there?
This was perhaps the most striking difference, though again, caution is needed as it wasn't the primary focus. The 30-day all-cause mortality was 11% in the high-dose group,
11%.
compared to 26% in the low-dose group.
Wait, run that by me again. 11 versus 26%. That's more than double the mortality rate in the low-dose group.
That's the difference observed in this cohort, yes.
Mm-hmm.
Overall, 21 patients died within 30 days, which is about 20% of the total group.
Which fits with those high mortality rates you mentioned earlier for BRSE in general.
It does. But it's important context that the authors noted most deaths weren't directly attributed only to the refractory seizure itself. They listed underlying causes like end-stage cancer, severe strokes, respiratory failure.
So very sick patients to begin with.
Often, yes. The refractory SE was listed as a cause of death in a couple of patients in the high-dose group and one in the low-dose group. The main point is the study wasn't designed purely to compare mortality, So while the difference is large and concerning, we can't say definitively from this study alone that the dose caused the difference in death rates.
Understood. A strong signal, but needs more investigation. Okay, crucial question. Was the higher dose safe? Did it cause more side effects?
That's key, and the answer seems to be no. The rates of adverse drug reactions were comparable between the groups. LEV appeared generally well tolerated, even at the higher doses used here. They reported things like agitation, some aggressive behavior, delirium, rash, sedation, but the percentages were low overall and not significantly different between the high and low dose groups.
So potential for more benefit without an obvious increase in harm, at least in this data set.
That's what it looks like.
Did they analyze the data any other way?
Yes, they use something called a win ratio analysis. It's a bit complex, but it's a way to look at multiple outcomes together, prioritizing the most severe ones.
How did they prioritize?
They ranked them. Avoiding death was the top win, then avoiding ICU admission, then avoiding intubation, and finally achieving BRSE termination.
Okay, so it bundles the key outcomes. What did the win ratio show?
The overall win ratio was 2.78, and it strongly favored the higher dosing strategy. Meaning that when you consider this whole package of important outcomes, patients in the high-dose group had, on average, nearly 2.8 times the chance of having a better overall outcome compared to patients in the low-dose group.
Wow.
And they found this benefit held up even when they looked separately at older versus younger patients, or those with versus without a prior history of epilepsy. The higher dose seemed consistently better across the board in this analysis.
Okay, those results seem pretty clear, at least within this study. So how did the authors wrap this up? What's the main conclusion?
Their main conclusion is that in their cohort of adults with BRSE, a levetiracetam loading dose of 30 mg or higher was, 1, more effective at terminating the status epilepticus based on their surrogate marker.
Right.
And 2, it was associated with significantly lower rates of really serious clinical outcomes needing intubation, needing the ICU, and 30-day mortality. And importantly, this came without a noticeable increase in adverse effects.
It's interesting that they found such a positive result when you mentioned earlier that some previous studies hadn't.
Yeah, and they discussed that. They suggest that maybe the way they analyzed the data using these more sophisticated statistical methods like the adjusted regression and the win ratio might have been better able to tease out these relationships compared to simpler comparisons used in some older retrospective studies.
Makes sense. Did they link the findings back to how the drug actually works in the body? The pharmacokinetics?
They did. They argue that needing a higher initial dose makes sense given LEV's properties. It has what's called linear kinetics.
Meaning more drug in equals proportionally more drug in the bloodstream.
Pretty much, yeah. And it has a high volume of distribution.
It spreads out a lot in the body tissues.
Exactly, which means you need to pump a good amount in up front, that's the loading dose, to quickly get the concentration high enough where it needs to be, especially in the brain, to actually stop the seizure fast.
So a bigger initial hit overcomes that wide distribution to get effective levels quickly.
That's the rationale. They even cite another analysis, a meta-regression, which suggested that doses around 40 mg/kg might be needed just to hit the target serum levels thought to be effective in refractory SE. So it all points towards higher weight-based doses being potentially necessary.
So practically speaking, what are they suggesting clinicians might consider doing differently based on this?
Well, based just on these findings, they suggest that starting LEV for BRSE with a loading dose of at least 30 mg/kg and maybe even aiming higher, perhaps towards that 60 mg/kg recommended in some guidelines, always keeping the 4,500 mg max in mind, might lead to better patient outcomes than using lower doses.
That could be practice-changing guidance if confirmed, but you always have to talk limitations, especially with retrospective studies.
Absolutely. And they are upfront about them. Looking back at records means you can't control everything. There could always be unmeasured factors, some bias in which patients got which dose, even though they tried to adjust statistically.
You're limited by what was written down.
Exactly. The sample size, 106, while decent, was smaller than what they calculated they'd ideally need, around 314, to be really confident about detecting differences, especially for those secondary outcomes.
And that surrogate marker for seizure termination.
Right. Relying on not needing another ASM isn't quite the same as knowing for sure the seizure stopped clinically or on EEG. It's a practical choice based on available data, but it's still a limitation. And data was limited to the electronic record, so nuances might be missed.
Okay, so compelling findings, but interpret with appropriate caution given the study design.
Precisely. And that's why they strongly call for more research. Specifically, they highlight the need for future prospective studies.
Studies designed from the outset to compare these doses.
Yes, ideally randomized controlled trials to really confirm these findings and establish definitive guidelines for the optimal LEV loading dose in BRSE.
So, wrapping this deep dive up, what this research strongly suggests is that when facing benzodiazepine-refractory status epilepticus using a higher weight-based loading dose of levetiracetam, this study used 30 millisecond as the threshold seems to do a better job at stopping the seizures.
And not just that, but it was linked to really important improvements in patient outcomes. Less need for ventilators, less time in the ICU, and potentially even lower mortality. All, crucially, without apparently increasing side effects.
For clinicians listening, this offers potentially vital clues for managing a condition where every minute counts. And for anyone interested in emergency care or epilepsy, it's a clear example of how refining something as seemingly basic as medication dosing can make a huge difference.
It really underscores that, doesn't it? And it also shows science in action. This study provides compelling observational evidence, it refines our thinking, but it also clearly points the way for the next step, confirming this with prospective trials. And maybe it leaves you, the listener, with a final thought to chew on. We heard about the benefit of the higher LEV dose, Ray. But remember that earlier observation about the initial benzodiazepine doses sometimes being potentially too low.
Yeah.
What does putting those two pieces together tell you about the chain reaction in emergency seizure management? How critical is optimizing every single link in that chain, from the very first drug given to the second to the third? How much impact can research like this have on those split-second decisions that genuinely change lives?